Okay, now it looks like it's actually going. Just waiting for it to show up on the Instagram. Yeah, I don't know if it's the light or something or what it was, but something made it where it was making that part. But so anyways, give it a second here for things to come on, but hopefully, people are going to be excited about this one. I love PCOS. It's like, to me, it's like one of my most favorite subjects. So I'm really excited about this episode with you. And I'm hoping a lot of people will be excited about it as well. And kind of go over things. So I really hope people come in and ask questions as well. So you want to start off? I mean, Dr. Salem, kind of tell me, tell me what you think about PCOS, or, how we can start this. And
yeah. I mean, I think one of my favorite things about PCOS is, like, we always get this question as REIs that we're like, are you guys experts? Or, are you an expert in PCOS among REIs? And I'm like, every REI is an expert in PCOS. It's probably the most common reproductive condition we sort of deal with. And it's honestly so common that I don't consider it to be anything but a variation of normal. Like, 5 to 10% of women at least are affected by PCOS. And it's a whole spectrum of conditions that are all bundled up into what we call PCOS. So in other words, just because you have the name PCOS doesn't mean you have the same type of way that the PCOS manifests as your friend who has PCOS. So I think that's something that I'd love to talk more about today, is like how PCOS can kind of manifest in totally different ways and have very different meanings for different, women. And, the biggest point to that is that some women with PCOS never even know they have PCOS, never have, fertility challenges, etc. And then get a diagnosis at some point and they're like, oh, interesting. And other people are, very severely affected by it. We see them for the fertility end of things. Dermatologists might see them for the acne. Maybe a psychiatrist or psychologist is, checking in with them about some of the associated psychiatric conditions that go along with that. So, it's a big spectrum. And I think hopefully today we'll have some people hop on and we'll hopefully have people, talk about what it is that has affected them with PCOS and what they would like to know. Because I'd love to, kind of chime in wherever they might think it's helpful. But I don't know. I think it's just kind of a launching point. I'm curious to know on your end, Dr. Amos, if and I'll start it off kind of like vague, but do you think we're making progress on PCOS as a field?
Yeah, so I think you stepped on this a little bit earlier where you said, that is everyone an expert? And like I said, I mean, you cannot become a fertility doctor and not be an expert in PCOS. I mean, it just wouldn't make sense. I think, though, outside of fertility, it's probably one of the most undiagnosed things by OBGYNs, by family doctors. And if anything, people are diagnosed when they don't have it. I see lots of patients who are told they have PCOS, and then I see them, and really they have metabolic disease, and they have severe diminished ovarian reserve. And what's happened is that just like anything, there ends up being this kind of view of it, that we have phenotypical view we see. And one of the biggest problems in PCOS is that if a woman happens to be slightly overweight and has irregular periods, they get told they have PCOS. No, they won't even do testing half the time, I'll give you another example of like polycystic ovaries. A lot of doctors think that you have to have polycystic ovaries to have PCOS. And if you don't have, let's say you only have 8 follicles in your ovary, they go, well, you don't have PCOS. But in reality, the actual criteria is 12 or more follicles on one ovary, or a volume of your ovary above 10 cubic centimeters. And so you can have less follicles and have that enlarged ovary, and that's still diagnostic of PCOS. So I think we're getting better as fertility doctors, but I don't think we're getting better in society. What I would love to see is a teenager who comes into to the doctor and says they have irregular periods, and the doctor doesn't go, well, here's some birth control, but instead defines it as PCOS early. So then that way that young woman can forever be treated for it, right? So it says, hey, when you're not trying to get pregnant, you need to be on this, because otherwise you're going to get hirsutism, stuff like that. And, unfortunately, we see these women after they've had high androgen levels for a period of time, and now they have to undergo things like, electrolysis to get rid of these hairs. And really, when women come to see us, it's for fertility. Matter of fact, I even just saw one of the people in our chat room say, I didn't get diagnosed until I saw you for fertility. And that's actually really what happens. And that's a shame, because it shouldn't have to come to a fertility doctor to diagnose PCOS. It is such an easy diagnosis to make. And so I do think it's important that we get better at it at the level of the primary care and better at OBGYNs.
Yeah, absolutely. And I think it's, so what you're saying is, we could probably get a lot better with the diagnostics of it way upstream. And with that, we're probably going to get better at treating you earlier and better. Is that kind of what I'm hearing?
Correct, because my fear for PCOS isn't even the fertility. The fertility part of PCOS is one of the easiest things. Matter of fact, I think most people get pushed into the wrong treatment with PCOS. I can't tell you how many patients I see from other doctors where they have PCOS and they just throw them in the IVF. Mm-hmm. And as you and I know, that IVF isn't always the best treatment for people with PCOS. Sometimes that they can do it, but you have to treat them different than everyone else.
Right.
But to me, the more important thing is like, the quality of life, right? If I can get someone their PCOS treated early on, I can reduce the risk of having things like gestational diabetes mm-hmm. for themselves, heart disease later in life. I have one patient who had endometrial cancer.
Yeah.
And what was amazing is this woman had central obesity. She had acanthosis nigrans. She didn't have regular periods, but once in a while would have a period, right? And, told her doctor, and the doctor's like, oh, well, you're getting periods. That's okay. And if I would have seen this patient right away, I would have said, listen, your periods don't seem clockwork perfectly. Let's just check it to see if you're ovulating. But no one did that. She developed endometrial cancer, something so preventable. And so it's just that teaching the other doctors that kind of point that don't look at PCOS as a fertility problem. I look at PCOS as a fertility problem like I see a guy with erectile dysfunction as a fertility problem. It's not, the problem isn't the fertility. The problem is the PCOS. And that's where I said, I actually love PCOS. And like, I don't even care about the fertility part, meaning, of course, I want people to have babies. And like I said, I could talk literally this whole show just myself about PCOS. So I want to make sure I don't talk too much, because it is in an area that I even did research in. And, and so it's just something I really, really love.
No, I totally agree with you. And I think there's so many facets to it. I was just with a patient the other day, and this is kind of part of what inspired, I think, this topic. And she was kind of like floored that, hey, PCOS can cause all of these things. And you've mentioned a few of them already, but maybe we can kind of bounce some of these around as people come on and ask some more questions. But, one of the things that they were really kind of confused by was like this idea that it isn't just a fertility issue that it can cause, it's all these other things. So maybe we'll just take a few of these as examples. I mean, you just talked about some cardiovascular issues, insulin resistance. One that comes to me that comes up very often is, women that get diagnosed with this early in life, they tend to be diagnosed by a dermatologist. They go in, they have, really pretty significant acne. It's the type of acne that doesn't seem to get better with any of the like first line, medications, those kinds of things. And dermatologists are great at treating the, skin effects of PCOS and the acne that comes along with it. It's very common to have acne. It's very common to have increased hair growth. For some women, we see the acne happen, when they're kind of in their years of going through puberty and post-puberty, their 20s. Now, some of their friends maybe aren't having the acne that, they're still experiencing in their 20s. And that distress can kind of get them to go to a dermatologist, and that's where they make the diagnosis. But later on, they can also get like hirsutism or increased hair growth. And, that also can be an issue and something that is not just a clue that it's PCOS, but it's also something that, women want to get addressed. And there are a lot of ways to address that. I mean, there are medications, of course. There are, there's like laser therapy that works really well, depending again on the color of the hair. So dark hair on lighter skin tends to work like the best combination there for laser. There are kind of mechanical things, of course, shaving, things like that. Birth control can have a little bit of an impact with it as well, as it increases sex hormone binding globulin and kind of soaks up a little bit of the extra androgens that are around. So again, I think one of the important things here for PCOS is we work collaboratively. And as REIs, I like to think like we're the quarterbacks of the PCOS team, and then we work with the dermatologists and the psychiatrists and everybody. But I do think it's important to work collaboratively. But what else? What other facets of PCOS do you have people asking you about?
Yeah, well, and I really want people to know, I mean, please come on the show. This is a really good topic. I mean, there are questions you have. I'm just seeing even when people are writing in here, some of the questions have, one of the questions someone that said is, why do so many doctors tell their PCOS patients they'll never have children? Because they don't understand the diagnosis. That's the problem. This is exactly where I go back to. They don't understand it. They don't even want to deal with it. Matter of fact, most people, when they see PCOS, are just like, do you want to have kids? Okay, I'm not going to deal with it right now. And that's the problem. But I think this is the question that I think is really important. And that is this idea that no one's treating the root cause. This is a misunderstanding of PCOS. You cannot treat the root cause because the root cause is metabolic syndrome. So when you have PCOS, that is a predisposition you have. This is something that runs in your DNA. Matter of fact, people who have PCOS, if you look at their brothers usually have little beer bellies. If you look at like the women, when they have overweight, it's usually in the stomach. Usually there's diabetes in the family, or the women have gestational diabetes, even if they're skinny. So when we sit there and say the root cause, you can't get rid of your predisposition. However, you can still treat the root cause being the metabolism issue at the mitochondrial level. And so when you say, why do sometimes treat the symptoms? Because that's what patients want. So when someone comes in and says, oh, I have this dark hair, they put them on birth control, or they do things like that. They have acne, they try to treat their acne. Treating the root cause is not easy. It depends on that spectrum of PCOS. And I think this is one thing we should define for people is what is PCOS. And so I don't know if you want to start first, because again, I'll talk the whole show, like the NIH criteria. So prior to the Rotterdam criteria, back in, I think it was like, 2003 or something like that, there was the NIH criteria. And so as Dr. Salmon could tell you that, the way we defined PCOS was we said that you had to have amenorrhea and you had to have elevated testosterone. And those are really, that was the true definition of PCOS. And in Europe, they were using also polycystic ovaries as part of the diagnosis. But we didn't do that in America. And so in about 2003, they came up with a consensus called the Rotterdam criteria, which, as someone noted in the forum there, that 2 of 3 things, if you have 2 of the 3 criteria, you have PCOS. But what's important to understand about that, when they changed that, they really changed the spectrum of PCOS. Because prior to that, the people who met the criteria really had significant PCOS. I mean, they had the Hirschsprung. It was the worst of the disease. Think of it like that. When they did the Rotterdam criteria, it brought in people who maybe don't even get periods. So they may get periods every single month, but now they get acne and they have polycystic ovaries. And so a lot of the issues that the other patients were dealing with, they're not dealing with. And so what happens is we have this very wide spectrum now. And it truly is. You can see these girls who are skinny, who get pimples on their face and have polycystic ovaries, get their period, and they have PCOS. And then the other end of the spectrum, you have women who could be severely obese with endometrial cancer. They can have type 2 diabetes, never get a period, hair all over their face, hair all over their breast, and they also have PCOS. Now, clearly, those are 2 different groups, but they all still come from the same source, which is mitochondrial dysfunction, which is what is called metabolic syndrome, and the severity of it over that span. And so We get back to defining this. And now, Dr. Sam, I don't know if you've seen this. I've been doing this for a long time, but I even saw recently someone was talking about, maybe it was a paper or something, about now even using AMH as a criteria for defining PCOS. I use it to kind of help me know if someone has it, because it's something I feel like if it's elevated, I go, okay, they definitely have, PCOS, versus those ones that are like borderline where I'm like, you have it, but you're far on the left on this side.
Yeah, no, definitely. I mean, I use it the same exact way. And I think probably if I had to guess, I would bet that the vast, vast, vast majority of REIs use it the same way. I mean, it's not, technically we now are supposed to use the Rotterdam criteria for, diagnosing PCOS, where you have to have 2 of 3 things, just like Dr. Amos was saying. And you have to make sure that it's not something that, walks and talks like PCOS, but isn't PCOS. It's kind of like a red herring there. So what we're, trying to do really is make sure that we've excluded the other things that are similar to these types of metabolic syndromes. And there can be some confusing ones. And, I have to say, over the years, I've had quite a few patients come to me. They were diagnosed with PCOS, but it turned out to be a completely different thing that just looks like PCOS, and totally different treatment too. So in those cases, I do think, it becomes really important to go through the criteria. But to get back to your point about AMH, when you see these really high AMH levels, it does, really, really, really lead you to think that it is most likely PCOS. And then you kind of go through the rest of the diagnostic criteria and you say, yep, this certainly looks like PCOS as well. So I see some questions are coming in here, so we can tackle these. Do you want to bring one of them up first here, Dr. Amos, and see which one we can take on?
Yeah, I think, for people asking questions, again, I hope someone comes on there live, because really this discussion would be helpful. It was something we were just talking about with like the AMH, and understand the diagnosis, understand the problems. Problems for PCOS can be, people talk about weight loss, struggling with weight loss, struggling with things like a thing called acanthosis nigrans, which can be this brown discoloration on the back of the neck, hirsutism. So again, if you guys have questions about this, please come on the show. I think you'll really enjoy this conversation, and I know we will too. So yeah, let's pull up some of these questions. Do you want to pull one up for me, or one that you read so far?
Here, let's see. This is a good one here. So somebody asks, what is the test for diagnosing PCOS? So this is a good one, because it kind of dovetails into like what we were just talking about. So the short answer here is there is no one test for diagnosing PCOS, and this is important to know. There's a panel of tests that we do to look at PCOS to kind of make sure that you get included in that group that's PCOS if you meet the criteria. So what are the tests? Blood work, an ultrasound, and honestly, a physical exam. So very broadly speaking, what are we looking for on the physical exam? Some of these signs, right? Like the darkening around the neck or around the axilla. Some of the signs we're talking about of hair growth in certain patterns. Now, of course, hair growth is also, ethnically dependent, right? If you are, Japanese versus if you are, Mediterranean, you're going to have different, distributions of hair growth. And so you have to take those things into consideration. And then the blood work, we generally look at androgens, total and free testosterone being the most common ones. But we also look at some of these cardiovascular and metabolic, panels to make sure that somebody doesn't have increased lipids, doesn't have high triglycerides. And we look at their blood pressure, things that go along with metabolic syndrome, like Dr. Amos was saying. And then finally, the ultrasound, which is meant to look for this classic polycystic appearing ovary. So basically, end of the day, exam, ultrasound, blood work, and pretty quickly we'll know if you have PCOS versus something else. What else do you want to add to that, Dr. Amos? I'm sure I missed something here.
No, you didn't miss anything at all. But the one thing I think that's important that you were bringing up is the fact that it's a syndrome. And this is a common thing that people don't understand about syndromes, is that a syndrome is not a diagnosis. So, if you have diabetes, blood sugar over 126 fasting. If you have hypertension, you have a blood pressure over a certain number. But a syndrome is something that says, if you have some of these characteristics and you have this characteristic, you might have this syndrome that comes with other problems. So when you even think of something like Down syndrome, yes, chromosome 21, having triploid of that gives you Down syndrome, but it's the syndrome. Why it's called a syndrome is because there are other medical issues associated with it. And the same thing happens with people with PCOS. So I know if I diagnose them with PCOS, it's not just fertility. Yes, that's the one that gets all the noise, but everything that comes with PCOS is what we look at. So what Dr. Salem is saying is that it's kind of a diagnosis of exclusion. So for example, if you're not getting periods, but you have dark hairs, but then we find out that you also have a condition causing you not to get periods, it's not PCOS anymore. It was a different condition, and the hairs could be for some other reason. So you were mentioning about having patients been diagnosed incorrectly. Same with me. One that comes to mind, it was a crazy case, was this patient came to me and they were trying withdrawal bleeds. She wasn't getting withdrawal bleeds. They said she had polycystic ovaries. She had hirsute features. And I'm like, sounds like PCOS, And then I see her, and she's this kind of thinner lady, definitely, dark hairs, hirsutism. Her voice was a little bit deeper. That was a little strange. And so I asked her, I said, hey, your voice, it seems a little deeper, and she's like, oh yeah, allergies. I'm like, oh, okay, very nice. And when you talk about exam, I, go to the exam, and she has a very large clitoris. And I'm in my head going, holy moly, this is strange. And just so everyone knows, clitoral enlargement can never happen with PCOS. That is what we call virgulism. So it's a little bit different than hirsutism that you can get from low testosterone levels. And so right away, I'm like, hey, is this normal? Has this grown? And she's like, well, my husband hasn't said anything. I'm like, well, that didn't help much. So I go ahead and do the ultrasound, and I'm thinking, gosh, she's got to have some high level of testosterone here. And as soon as I look at her ovaries, I'm like, she has cancer. And what was crazy about it is that they saw these ovaries, and they were polycystic, but they were polycystic from a granulosa cell tumor that was producing high levels of estrogen. Well, obviously, when it's making that, it had high levels of testosterone, thinned out her lining. And here it was. Thank goodness we found this so early. She was completely cured. But it's one of the things where even the doctor who sent it to me was like, oh, I can't believe I missed it. And I said, listen, that's why I'm glad you sent it to me. And that's why we're the specialists in this, You remember that saying? Have you ever heard that thing about PCOS where it says I loved it. I always thought it was funny. It's PCOS is like porn. It's hard to define, but you know it when you see it, type of thing, And so I've always found that kind of a funny quote. But yeah, I think that's an important thing for people to know is that it is a syndrome. It's not a diagnosis. There's no test that can just define you with it. And there probably are people we're overdiagnosing and underdiagnosing because it is a syndrome. It's not perfect. One of the things is for example, how people say, well, no one checked my testosterone. Well, you don't need to really check testosterone if someone has hirsutism. Clearly, they have elevated testosterone. But if the hirsutism came overnight, then you're worried about things like, okay, is this elevated testosterone that can be virgulism? And that's when you start seeing those other features. And that's where Dr. Salem was talking about why the exam is so important. It doesn't have to be a super big exam. It's just trying to figure out these things.
So what you're saying is, again, and I think we're both saying this, but is that PCOS can be diagnosed differently for different people. And on the same token, different people might even undergo different tests and all land with the diagnosis of PCOS.
Absolutely. I mean, I it's like I just said, I mean, I see a patient, I know right away. I'm like, she has PCOS. I know. And then there's other people come in my clinic who are diagnosed with it, and I know right away they don't have PCOS. The one that I think the one that really scares me the most are these more mature women I see who are in their 40s who don't get a period, and just because they're overweight, they tell them they have PCOS. And so instead of coming to see me, they tell them oh, let's put you on Clomid and stuff like that. And then I see them and they have severe insulin resistance and very severe diminished ovarian reserve. And why those look the same is because, again, that severe diminished ovarian reserve, the insulin resistance creates a very similar environment. And that's the thing about a syndrome. They can look similar because there's a lot of overlap in these different things. I saw one patient say something in here that I thought was interesting. And I've heard this from other doctors. Maybe you have too, but I'll post that one up here, which was right? It was the different types of it. Here it is. So can you discuss the different types of PCOS and how they manifest? And that's really interesting because there's like even a doctor in town here who like goes on and tells people like, oh, you have type 1 this, or you have type 10 of this. And he just comes with all these different diagnoses of PCOS, which I'm like, well, that doesn't exist. That's just made up by that doctor. And I know academics, like, when I was doing research, like, yeah, we kind of knew which were like, okay, those are the PCOS that are like the NIH criteria PCOS, and then those are the Rotterdam criteria PCOS. But in the end, ask this question about inflammatory insulin resistance. I think they all have all of this. It's just the spectrum of how severe it is. I mean, do you break it up into type 2 PCOS or type 1 like you hear some people do?
No, not at all. Not at all. I mean, I think that I think that's magical thinking, in all honesty. I mean, I think that the reality of it is it's a very complex syndrome, and we're going to understand this a lot better, I think, in probably somewhere in the next 5 to 10 years with genetics. And I think there are going to be different genetic fingerprints of multiple genes interacting that will kind of give us a little bit more of a clue as to what's going on with the different, subtypes of PCOS. But to kind of categorize it clinically at this point, it's just not that helpful right now. I think you have to look at the various parts of it and try to address, like, if somebody has rip roaring insulin resistance or flat out, type 2 diabetes, we got to address that. But to break it up into, type 2C PCOS, it's, yeah.
Exactly. And one of the things, like, I think this is where there's some confusion. So, for example, in our Instagram live, one of the people asked is, if a patient doesn't have metabolic syndrome because they have a normal A1C, and no obesity, well, that's again assuming that you have metabolic syndrome, because the thing about diabetes, the thing about hemoglobin A1C, it occurs after the problem. So think of it like this: when your glucose levels go up, your body makes insulin, brings the glucose levels down. And it works pretty well. Now, what happens is it starts not working perfect. And so now when your glucose levels will go up, your insulin levels go even higher, and they stay up higher for a little bit longer time. Now, technically, your glucose levels go back down, so your hemoglobin A1C looks normal. Your fasting glucose looks normal. But if you did a 2-hour glucola test, you would actually see that it's not normal. The hemoglobin A1C does not start going up until it starts failing, at the point where your body can't bring the glucose levels down. You still have the metabolic syndrome, but it's the very early portion. You haven't developed the disease state yet. And so it's really important to understand that, like, if you have PCOS, you have it in your body, and it's a predisposition. So I bring this up to people when I say to them, like, diabetes in your family. If you have diabetes in your family, you're at risk for developing diabetes later. Now, you can do things to prevent it by, having healthier lifestyle, right? Working out more, keeping weight down. And there's a point where your weight gets there where it actually then can flip you into that diabetes. And it's not the weight that causes it, it's the predisposition. And this is one thing I try to get across to everyone, because I hate more than anything when people think weight is causing their infertility. Even if you have PCOS, it just drives me insane, because you can be extremely overweight, have kids, no problem. And it's trying to get people to understand that it's that metabolic syndrome, that PCOS that you have, that's causing the problem. The weight does make it worse, but the weight's making it worse the way gasoline makes a fire worse. If someone has a bowl of gasoline, you don't go, oh my God, there's fire. You go, well, no, it's nothing to do anything. It's just gasoline sitting in the bowl. But if there's a fire there and now you're shaking around the fire, people are like, hey, be careful. That's going to make the fire worse. And that's how I look at PCOS. That weight is the gasoline that makes it worse. And so when we go back to all these different things, like, PCOS is such an amazing thing. And unfortunately, we only talk about it from fertility standpoint. But one of the things I wanted to talk about tonight was for the people who do struggle with weight, like, what can they do? Because most doctors tell them the wrong thing. They tell them, oh, you need to work out. You need to be healthier. And that's not true. There's a very famous study that was done where they looked at weight loss in women, where they looked at women with BMIs. I think I've talked to you before about this. So BMIs of 25, 30, 35, and 40. All of the women worked out for 5 hours a week. Moderate exercise. Calories were kept the same, so they never increased their calories. No one lost weight in that. And what's interesting is not only did no one lose weight in that study, what they found is everyone gained weight except the people with a BMI of 25. And the reason why, it doesn't make sense at first, but PCOS causes that metabolism to change where your caloric requirements are different. And so if this is your caloric, what you're taking in, and this is your requirements, even with the working out, they didn't lose weight because it never dropped down far enough. And this is the important part about PCOS. It's a metabolic problem. And once people realize that, don't go at it from exercise. I'm not saying exercise is not good, but do it through weight-bearing exercise. Make sure you're using muscle, building metabolism. And then the second thing is caloric restriction. Like you can do it through different ways. You do Mediterranean diet, you can do your one, but it has to be low carb, or it has to be like low calories. That's the only way to break the cycle. And then once you break it, here's the crazy part. And I don't know if you've ever dealt with this or something, because you look like you've been skinny your whole life. I was skinny for most of my life. And then I hit like 40s and I just, couldn't keep the weight. And I was constantly going up and down, up and down. And I had the same problem. I have metabolic syndrome in my family. And what happens, and a lot of the women who have PCOS are going to be like, yeah, this happens to me too, is that you kind of hit this weight. And then from that point on, you do the same thing that you've always been doing, and you just keep gaining weight. And you're like, what the hell? And then you start lowering the calories. You still keep gaining weight. And you're like, what is going on here? Like nothing I do works. And they're right. But it's not because nothing will work. It's because at that point, it is feeding itself with the metabolism and the inflammation and everything that you have to shock the system. You always have to go and go like, no, I'm going to go down to, and like I had a patient today going, oh, I did caloric restriction. I didn't lose any weight. I'm like, well, how many calories did you take? She's like, I was doing 1,600. I'm like, well, that's not enough. I'm like, a normal for women is like 1,200 to 1,500. So I'm like, there's 1,600 is not a low calorie. I mean, you got dropped into 1,200 to 1,000 to really shock the system. And that's the point, is that these are the things I want people to learn. I want people to learn that PCOS can be managed very easily. But if they can start it early, they can have a great life and not dealing with electrolysis, not dealing with hirsutism, not worrying about pregnancy and stuff like that. But anyways, again, I can talk the whole show about this. I love PCOS.
Yeah, no, I mean, I think that's wonderful. I think you hit on so many good points there with the diet and everything. And I think, it's really tough. I think it just, I have a lot of women in my own family who have dealt with it. And it is a very difficult diet to sustain, to continue losing weight on. I will say that much. I think it's interesting that some people have found different ways to do it. I'm curious about these GLP-1s, and things like Ozempic and stuff like that, because I do think they might play a role. I think they might play a significant role. I don't think they're first line. I don't think that's the first place I would go, because I think it's hard to stay on those medications. They have a lot of side effects. I think it's that 1 in 5 people come off them because the side effects are so bad. But there's a group of individuals that might have a little bit of benefit with them. And I think I'm interested to see how this is going to change some of the dynamics with PCOS.
Absolutely. What's your thought on Novastol or myoinositol? I'm a big proponent of it, especially for women who don't have severe insulin resistance. Like, like when you're not seeing acanthosis nigrans, or you're not seeing the things that would make you worried. And just so for people to understand, acanthosis nigrans is a side effect of high insulin levels. And the way it shows up, you can Google it. So AN, but acanthosis nigrans. A lot of times on the back of the neck is going to be one of the first places. You'll sometimes get under your breast at the very bottom. You can get on your armpits. Any type of crease that's like rubbing together where the skin goes is where it can develop. And the darker it is, probably the more severe it is. And so I tend to, if I don't see that, I will actually just put them on myoinositol, because although metformin's a great drug, it's not well tolerated, just like you were talking about with the other medications like Ozempic. What's your thought on that? What do you do with that supplement?
It's so funny, right? So I was a total naysayer on a lot of supplements. And I was like, well, the research isn't so great, that this and that, and of course I've come around with inositol. There is actually really quite good research on inositol in particular. And the mechanism for it totally makes sense. I mean, especially it's kind of, works as a, second messenger for increasing, insulin sensitivity within the cell. So kind of getting the sugar out of the blood a little bit more quickly. And practically speaking, this is a big part of what we do as doctors is we just look at patterns, and we just, have hundreds and thousands of patients, and they try these things, and you just listen to their stories, and you also have this experience. And my experience with myo-inositol, and there's this company called Ovasitol. I have no relationship to the company. Wish I did, but I don't, because they sell really well. But they basically, a lot of people have gone on these medications or these supplements because they're sold like over the counter. And quite a lot of women have had a little bit of weight loss, a little bit. I'm not saying it's a lot, a little bit. Some women will start cycling more regularly, will start having LH surge more regularly. A few of them, I've even seen their hemoglobin A1C trend down a little bit. I do think in our world, it may improve egg quality. I really do believe that, based on kind of what we've seen over the years with women who have PCOS as they, are on these medications. And then, of course, we know it has a role even for embryo transfer. Lower sugar levels, lower hemoglobin A1Cs are advantageous to doing an embryo transfer. So, man, I feel like I've drank the Kool-Aid on Ovasitol.
Yeah. And just so everyone knows, Ovasitol is a brand name one from Theralogics, which, you can use. And if you ever need a code, you can use my Taco Bell Fertility Tuesday code, tacos. That's the code that you have to put in, tacos. I think you said this earlier. When I first started, I really, a lot of people struggled with PCOS patients with IVF. I mean, matter of fact, reason most patients are afraid to do IVF is they read about these women who get like 40 eggs and one embryo, and all the embryos are stalling. And it's true. I used to see that a lot. And then I made an adjustment. And one of the adjustments I made, I do with every single patient with PCOS, even if they're on the lower end of the spectrum or the higher end of the spectrum, is I go after that metabolism. So I tell them they got to be on myo-inositol. If they have acanthosis nigrans, I even add metformin. I do both. Yeah. I tell them during the stimulation, I want them to be on a low carb diet. And I want it to be seriously low carb. Like I tell them it's either keto or it's like a very low carb diet. Yeah. I also give a steroid. I give dexamethasone during it. All this to go after that inflammation. And the reason I don't have people do the low carb diet for a long time beforehand is it's hard. I mean, I don't know if you ever tried keto or any diet. Like it's hard to do it for weeks and weeks and weeks, but anyone can do it for 12 days. So I feel like, hey, if they do it for 12 days, ever since I've started that, I have never had another case of those severe, like high numbers of eggs and then have like real bad embryo quality. And so I just wondering, like, it's a big change I made because I was doing like everybody else. Like we didn't know better. We're like, give them meds and make a bunch of eggs. And everyone started realizing, hey, you make too many eggs, the quality went down. And so then everyone started backing off and making fewer eggs. And then I started doing this and I realized, wow, I can still get lots of eggs and have good quality still. And so I just wasn't sure, like, how have you changed yours? Or maybe again, you've been doing this the whole time.
No. I wish I could take credit that I've been doing this the whole time. I think it's one of those things that with some years of experience, as you start seeing that you can't, especially for certain types of PCOS, like you said, these ones with a higher insulin resistance, et cetera. I think investing, 4 to 6 weeks sometimes and really trying to do these lifestyle adjustments just makes such a big difference in terms of doing, one IVF cycle, doing it right. And sometimes, like a slight workaround on that is some patients, with PCOS, their first best shot at pregnancy is IUI. And so, we start there, but while we're doing IUI, we go, really aggressively on these things that you're talking about, getting the, myo-inositol on board, decreasing sugar, cutting out carbs to the extent, absolutely possible, just fine tuning all these things. And then a lot of times they get pregnant on IUI because we've improved the metabolic environment. Things look great. And for those that aren't as lucky, well, we go into IVF with a really, 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 on really solid footing because now we've improved all these metabolic things and they tend to do really well. And I kind of, somewhat jokingly say, like, if I could pick one diagnosis to have going through IVF, I think I would pick PCOS because they tend to do pretty darn well once you kind of fine tune all these things.
But you have to fine tune them. And that's the thing that, like, I unfortunately, I part of the group that didn't focus as much on the metabolism at first. And, unfortunately, I had success with people, but not as well. I mean, those stories you hear about people getting 40 eggs and getting one embryo, that's what that's from. The other thing that's interesting about people with PCOS is when we talk about fresh versus frozen transfers. And if there's ever a group that has helped the most, it is patients with PCOS and frozen transfers, because you can do a fresh transfer of PCOS. The problem is because of that inflammation, because of the elevation of those insulins, their implantation rate, several studies have already shown already, is lower with a fresh transfer than now. If you only make like 5 eggs, 8 eggs, a very small amount of normal number, your fresh transfer will probably be fine. But if you make 16 plus eggs and you're going to create that inflammation, there's a lower chance of pregnancy. And so I know that's been a big benefit to people with PCOS too, is just that having that frozen transfer in some ways does benefit them. What are your thoughts on that? I mean,
no, definitely. I mean, I think we're seeing more and more evidence. I mean, over the last 5 years or so, we're really seeing this benefit with frozen embryo transfers, especially among women with PCOS. I think I think the data is, really solid on that end of things, because also you don't have this with IVF, their estrogen levels with women with PCOS tend to go really, really high. And so now we get to kind of press the reset button and take it more back down to natural levels when you're getting pregnant. It looks like that has a pretty important impact on the development of the pregnancy and the baby and everything. I did see a couple of questions coming in. Did you want to tackle a couple of these? Yeah.
Yeah. I mean, some really simple ones here. I saw one about, is Ovastol, which is myoinositol, safe during pregnancy? The answer is yes, we believe it's fine to take during pregnancy. And so, just like, by the way, metformin is one of those drugs that is technically safe to take during pregnancy, but in the United States, we tend to get people off of it. But in Europe, they actually keep people on it the entire time. There was another question someone asked as well about, I remember reading, it was asking if you can take myoinositol and metformin at the same time. The answer is yes. I do that all the time. The question I think would be a good one to go on. And by the way, I know it's a lot of people asking like, hey, do I have PCOS or would I have this? That's a perfect one to come on here. I know we seem scary, but look at our backgrounds. We're obviously not that scary. We have sperm and egg behind us. So there's nothing terrifying coming on here. And you don't even have to show your face again. But we can then answer that for you. You get basically a free consult while on air. But there was someone that asked a question about with endometriosis. They were like, can you have both? And so I think that'd be a good one for us to touch on. And since I'm just talking up a storm here, I'll let you get that one.
Yeah, no, it's a great question. So this is something that, has been very interesting to me over the years. So first of all, yes, you can absolutely have both. Unfortunately, they come kind of from two different pathways, and they're two different, conditions, diseases, syndromes, and treated really kind of differently, to be honest. The really tricky thing here, and I'd love to hear your take on this too, Dr. Amos, is my experience has been that women that are affected by both of these tend to have really compromised egg quality. And it is still dependent on your age. Younger women tend to do a lot better. As women get a little bit older, it's not, quite as, it can make a little bit more of an impact. But this is one of these combinations that can be really, really tricky. It can also be very deceptive. And why do I say that? Well, on the one part, endometriosis tends to cause a lower egg reserve for a lot of women, but PCOS tends to kind of cause what looks like a higher reserve. So sometimes they kind of almost meet in the middle, and you'll see what looks like a normal ovarian reserve, but really it's being kind of attacked by both, diseases, both syndromes, and you're getting this middle of the road number. Other parts of this that can be really tricky is that, one is a metabolic disease, PCOS, metabolic disease. It is mainly treated by, things that are very highly associated with lifestyle, maybe medications, things like that. Endometriosis, our best treatment, still surgical, up until now, our best. So again, very different, approaches. Just as a little trivia tidbit, they used to treat PCOS surgically as well, but that's an aside. We don't really do that almost at all anymore.
There's still doctors who do that, unfortunately.
Yeah, yeah, yeah. But what's your take on the combo of PCOS and endometriosis?
Yeah, before jumping on that, I wanted so people know what we were talking about. There's a thing called ovarian drilling. And so at
Mhm.
one time, we used to actually drill the ovary, and you either would take like a core of the ovary or you drill these little holes in the ovary. The American Society of Reproductive Medicine said, probably not the best option to do, especially if you're trying to get pregnant because it can create scarring and stuff and lead to some problems. However, I still do think ovarian drilling is not a bad idea, or taking an ovarian wedge if someone doesn't want to have kids. They just want to deal with the symptoms. And a lot of women, when they do that, they go right back to normal cycles and get rid of a lot of their symptoms. So there is a benefit to it. And the reason for it is, again, you're reducing the size of the ovary. So a lot of the production of the androgens and everything is going to be reduced. And so a lot of the inflammatory. You're right about PCOS and endometriosis. They have some things that cross over, right? And those things are going to be things like inflammation, right? And so, yeah, I think you're right about the poor egg quality, because you have PCOS, which if you make more eggs, you're going to have inflammation, higher estrogen levels, higher insulin resistance at that time. And then if you have endometriosis, you have, again, higher CRP, higher inflammation levels, and it just creates that, really poor environment. What I find interesting, though, is that there are some people who I think we think have PCOS, but actually have endometriosis. Years ago, I used to look at AMH as like, that's the one. If AMH is good, it's good. But I've over the years now have noticed a trend that if I get someone who doesn't have a follicle count that supports their AMH, I believe they have endometriosis. And so some of these patients, I don't know if they truly do have PCOS. Whether it really is just endometriosis masquerading as PCOS through the AMH and some of the symptoms, and the crossover. We just got done saying that, like, some of the things cross over the inflammation. So you're going to get these kind of similar appearances. I don't know. Again, me and my curiosity brain, I've been noticing this. I said this to you once before, and I don't know if I have enough to make a study for this yet, but I truly feel like AMH now, one of these days, is going to be a marker we can use and for possibly determine people who have endometriosis someday. But again, when you see lots of follicles, it's PCOS. I see we actually have someone who's willing to come on. Someone's not scared of you. You must be very scary, Dr. Salem.
I'm sorry. I do it to people. I don't know.
I'm very serious. So let's jump on this, just because we don't have as much time. So,
hello.
Hey, Jackie.
Hi.
Are you like in a car or something?
I am. I just got off of work and I saw you were doing a podcast about PCOS. So I was like, okay, yeah, I have to get on.
Yes.
Wonderful. Thanks so much for coming on. Yeah. Thanks.
Of course. So I have PCOS. I had no idea until I went and saw Dr. Ramols. And it was crazy. For years, I was put on birth control, many different types of birth control, because I had irregular periods. I would go months without having periods, and they were always really inconsistent. And it's been that way even through IVF. Once I gave birth to my daughter last year, all of a sudden my periods became very regular. And that was such a weird thing for me. And so I don't know if there's like any correlation, because obviously I still have PCOS. So I was always unsure like why that happened all of a sudden.
Yeah. Do you want to jump on this, Dr. Salem, or you want me to?
Yeah, I mean, this is a really interesting one. It's definitely something that we see. It's something that we see as people go, why don't you take it? Why don't you take it? And then I'll hop on. I have a little tidbit I was going to say, but yeah.
So I think, Jackie, the thing is I don't think it's so much specifically that event that caused it, right? Okay. So there's lots of people have PCOS, they have a kid, and they still have it. And you always have PCOS. You never get rid of it. Yeah. But what we find is things that change that metabolism, right? Things that an event that happen can lead to it. We do see this a lot. Mm-hmm. There's also that important part too, is, are you ovulating or bleeding, right? Because you can bleed every month and be hormonal. And so you have to look at it from both ways. But yeah, we do see this once in a while. Like, people have a baby and then all of a sudden, like, I would assume they were on that very mild end of the spectrum PCOS, right? Whereas I'm not going to expect the person who never gets a period all of a sudden, remember, if someone never had a period and said to me they had a period, I'd say, okay, something's not right here. That doesn't make sense. That all of a sudden you had a baby and that was the thing that changed it. But imagine you're like right on that part where you're like, okay, like me, like I'm almost cool, but I'm not cool, right? So it's easy to go like, oh, Mark became not cool very easy because he's right on that middle part.
Yeah.
And so the thing is that PCOS, if you're right on the edge where you're like, I could easily go this way and not get periods, easily go this way and get periods, just be that one event that pushes you over. And that's what we see in women. It's not like women have to lose 100 pounds all of a sudden to get their period. It could be something as simple as starting myoinositol. It could be something as simple as losing 10 pounds and all of a sudden their periods are back. So it's these little tiny things that happen that make this occur.
Okay. That makes sense. I actually had another question too, around PCOS. So obviously I listen to a lot of podcasts and read things about PCOS, and I've always heard that there is a slight increase when having PCOS to things like miscarriage. Is that true?
It is, but a certain type of miscarriage. Now, say, why don't you jump on this one?
Yeah, I mean, that is true. There's a couple of things that might play into that. I think one thing is, of course, if we see if it's a person that has PCOS and they have like pretty significant insulin resistance, or let's say they even have diabetes, then we do see an increased relationship between the uncontrolled blood sugar and having an increased risk of miscarriages from that endpoint. There's this question of, hey, are we seeing also an increased risk of miscarriages because of genetic aneuploidies? So compared to other women that are the same age, is it possible that we're seeing a little bit of a higher, potentially a higher pregnancy rate, but a higher miscarriage rate as well because of aneuploidies? And that's definitely been something that has been talked about a lot. But the short answer is there a little bit of a higher miscarriage rate? And the answer is yes. We do see a little bit of a higher miscarriage rate. But yeah, what were you going to say there, Dr. Amos?
I was just saying that basically, people at PCOS are going to have more likely have a luteal phase defect. One of the more common types of miscarriages you hear about when people have PCOS is that kind of early chemical miscarriage. So our women will come in and have these multiple chemical miscarriages. And then, once I realized that PCOS, I fix that. And usually they don't have those chemical miscarriages much. It's a big common one that we see in people with PCOS. That's why even myself, when we do things like IUIs, I usually will always treat with something like progesterone with my patients with PCOS, whereas others you can get away with not using it sometimes. There was something I wanted to say, and I can't remember it, but I'll think of it here. It was regarding some of this topic. So, well, thanks so much, Jack. Any other questions you have for us right now?
No, I don't. Thank you, though.
Thank you for being strong and show over everyone. We're not that scary. And I know Dr. Sam seems scary, but he's not. So
you're so welcome.
And we welcome people to join from the car as long as they're not driving. How about that?
Exactly. As long as you're not driving. Yeah.
Thank you.
Perfect. We got another person here that we're gonna talk to as well. So this will be kind of nice. Hey, Shayla.
Hi. Hi, guys. Thanks for having us.
Yeah.
Thank you for coming on.
So my question is, I know you talked about PCOS and how it can be like a genetic thing. With diabetes, there are things that can trigger that for that to be an issue. So with PCOS, is there things that we can like stay away from that can cause like flare an issue?
That's a great question.
Absolutely.
I mean, this is an awesome question. It's kind of like what the best medicine for anything is prevention, right? And so this is totally what you're getting at, Shayla. And the idea is, can we, if we know that PCOS is on the horizon, or we have PCOS, how do we at least like mitigate or decrease the chances of having, something, not so good come from the PCOS? And I would say a lot of it comes down to, well, I would say the first thing is you have a lot of control over it, which is wonderful. It's one of these condition syndromes in which you have a lot of headway to kind of plan for things, make arrangements in your life, etc., so that you're not affected by the worst of it. So what does that look like? I mean, a good healthy diet, generally speaking, a low carbohydrate diet, trying to keep added sugars down as much as possible, being active, but that doesn't necessarily mean, going out and training for a marathon. You can do that if you want, but I think a lot of people confuse, the amount of training you need to do versus what you just need to kind of stay healthy. Definitely strength training can be really helpful. That way it increases your metabolism. Easier said than done, but, maintaining a healthy weight for you. So a healthy weight for different people means different things, but a healthy weight for you is generally some place where you're eating healthy, you're exercising, etc., and you're not kind of yo-yoing around. For most people, those would be just some very initial starting things. But the other thing is being evaluated and getting checked out, making sure that you're also kind of doing your part to, check in on your blood sugar levels, your cholesterol levels, your blood pressure, all these things that you might be at higher risk of later on in life. And so just being a little bit more proactive with those things early on. So if you see a little warning signal early on, you can kind of jump on it right away, usually with lifestyle things, but if you have to, even some medications, at some point. So I think those are just some initial things that you could do to kind of prevent some of those aspects of PCOS. Yeah, I don't know. What do you think about that, Dr. Amos? I mean, what other things you usually tell people to watch out for?
Yeah, I look at that spectrum all the time. What I was telling you about, so it depends where you're on. I mean, I can look at you, Shayla, and I can tell you you're not on the severe side of the spectrum in some ways, but you might be hormonally or something like that. And different people can benefit. So, for example, let's say like you're overweight. Okay, as I mentioned, the weight is not causing the issue for PCOS, but the weight makes it worse. And so, for a person who has weight loss, they will benefit by losing weight. But if you're thinner and you have PCOS, losing weight is probably not going to do much. So then you got to focus more at the metabolism. And so my focus would be more on like, okay, keeping carbs down, being on my own inositol. You mentioned earlier about like exercising. Here's the interesting statistic most people know, and this is why I always tell people, focus more on diet than exercise. If you run a marathon, which is 26.2 miles, which is pretty long distance, you will only lose about a pound as a woman running that. Yet you can eat my favorite bag of Cool Ranch Doritos, okay, and family size, and you will gain a pound. So it's much harder to lose weight through exercise. And that's the point of that, is that with PCOS, the focus should always be on that metabolism. All the exercise is good, and it's good for heart health. And the reason why you want to do this stuff through your life is it's not even just about fertility, but, you can prevent a lot of the problems. And as you get older, you reduce the risk of heart disease, reduce the risk of diabetes and all these things, because eventually some of you guys are not going to be young anymore, just like me. I mean, I was a stick figure my whole life, eating whatever I want. And then one day I'm like, holy moly, my metabolism is not as good anymore. And when that happens to people with PCOS, they will start having some of these issues. Some of those problems and the inflammation is going to go up. When you're young, you have this high metabolism, it can offset some of this stuff. And that's why we see this wide spectrum of PCOS. Think of PCOS, honestly, as like pre-diabetes. Everyone who has PCOS has this kind of pre-diabetes. And just like people out there, it adjusts. So let me give you another example. It's kind of really interesting. So if you've ever seen men who are Indian, and I'm not talking Native American, we're talking Indian, those guys can gain 10 pounds, little tiny pouch here in their belly, full on diabetes. I get 10 pounds, I just don't look that good. I don't have diabetes, even though I have the same problem as them. I have metabolic syndrome in my family. Yet Native Americans, same thing again. That pre-diabetes, have to gain 40 or 50 pounds before they push themselves into that. So as you see, it's not one treatment for each person. And that's where I go back to PCOS is I actually think PCOS is not understood well. I think we still have to do more research and treat people really individualized. And sure, we can throw things at people and treat most of them, but it's a very, very complicated disease. Now, here's the other cool fact about PCOS. This is the one good thing about PCOS. There's really not a lot of good things about PCOS, but there is one really good thing. If you truly have PCOS and you have polycystic ovaries, the one benefit you will have over other people is when you get older, you have a better chance of being able to be successful with things like IVF because you can make more eggs and overcome the age factor. That's the only really good thing about PCOS. Other than that, I don't think there's anything else.
I like that glass half full. Why not? Like let's stick with that, because I do tell my patients the same thing. I say, okay, well, there's this and that, but that's okay. But looks like your ovarian reserve is higher, and we're going to get kind of more eggs. And we do know that at the end of the day, especially as you get a little bit older, if you're trying to do IVF, a higher egg count will generally correlate with a better outcome. Generally, and so that is a silver lining, I think, with PCOS. And I wanted to add one more point, because Shayla, you make a great point. A few people have asked us on Instagram about, women who become pregnant, when they have PCOS in the background, kind of predisposition to certain things. And one of the big ones is gestational diabetes. And it's just like Dr. Amos was saying, it's kind of like you have prediabetes when you have PCOS, or kind of prediabetes light, let's call it. And it can also increase your chances of having gestational diabetes. That means you have high blood sugars in pregnancy, and that can lead to the baby being born kind of too big, having issues with difficult delivery, needing C-section, and even needing insulin during pregnancy. So, your point, Shayla, gets to this idea very well, which is what can you do to prevent that? And it's so key here, because some women with PCOS in pregnancy will, even despite their best efforts, gain a lot of weight. That's just part of the syndrome, and their blood sugars will go up, quite high. And the only thing that they can do is try their very best to be really, really careful about the diet. Probably a lot more than other women. It's not fair, but at least you have that early warning flare.
Yeah. Great.
Thanks. Any other questions you have before we go?
No, I think you answered what I had. Thank you.
Of course.
Thanks so much, guys. I know we're getting near the end of time here, and we I'm not saying we can't ever go over, but I don't eat, and I know Dr. Salmon has a little baby at home, and so we try to end this close to 7. The one last thing I think we should go over, and is there's a question that I keep seeing everywhere, which is the GLP-1s, and whether those help. I'll be honest. As I was telling someone today, they asked me, why don't I do a podcast on that? And I said, it's not an area yet that we really truly know yet. So I said, it's kind of like COVID, where in the beginning, people said things, and if we went back and looked at it now, we'd say, well, that was wrong, but it was right at that time. And just like you can't do a study and go, hey, let's see if this hurts your baby when you take this, or let's see if this hurts your IVF cycle. I don't feel like we know it well enough, but there are some things we do know. And so I know you know a little bit more than me, Dr. Sam, about GLP-1s. I can tell people for sure that no question will benefit you if you have PCOS. I mean, it's hitting the crux of the problem, the metabolism. But I'd love to hear what you have to say, because like I said, you are a little bit better than me at this topic right now. So weaker for me. What do you have to say for people about, can it help with PCOS? Will it help with, some of the things? And then we can also tell them the dangers of taking it during IVF, because there are some problems that can occur if you're taking it during the stimulation stuff.
No, definitely. I mean, I would say, this is a very exciting class of medications. And I think that, I think I rarely say this about a new medication, but this is like a revolutionary medication. Our population is struggling with weight, with, the easy access to good calories. It's hard to keep the weight off. Let's just be honest. And we have all these conditions in the background, like PCOS, et cetera, that, a long time ago would have helped us survive. And nowadays they just make us a little extra fluffy. And it seems like these GLP-1 receptor agonists, things like Ozempic and, semaglutide, et cetera, they are going to have a role, a very real role for some individuals. The problem with them is it's not a one size fits all. They're medications that are appear to be very helpful in reducing the blood sugar levels. That was their initial focus. Actually, they were initially designed for decreasing blood sugar levels, and invented by a company that's all they do is metabolic disease. And it just so happened that they were also leading to pretty significant weight loss. Now, the problem with them is that, number one, not everybody tolerates them. They have a lot of side effects. The idea with them very, very, very simply is they make you feel full pretty quickly. So you eat less. This gets back to what Dr. Amos was saying, calorie restriction, being very, very, very cautious about the number of calories you take in. And this medication just kind of makes that easy. The other problem is they can make people, empty their gut more slowly. And that can, feel like bloating. It can feel like, discomfort. And I think, like, we were saying this earlier, up to 1 in 5 people will stop these medications, after they start them because there's too many side effects for them. Now, there are, individuals that I have seen that have been, very, very overweight and had insulin resistance or diabetes straight out, go on these medications. 6 months later, they've lost 60 pounds and they no longer have diabetes. It's a whole new person. I think that's revolutionary. I think that's amazing. And, they get their cycles back. They start, having ovulatory cycles. They start menstruating, and on TikTok and all these, on social media, we talk about Ozempic babies. Is that a real thing? It is actually a real thing. It's because people have lost weight. They've become, more insulin sensitive, and they're now having regular ovulatory cycles and they get pregnant. That totally makes sense. And this is just kind of serving as a crutch for that. Now, there are a lot of downsides to these medications. Number one, they're super expensive. So, if you don't have an indication not covered by your insurance, it is, cripplingly expensive. Number two, you can't take them in pregnancy. You have to come off these medications in pregnancy. We really don't know what the long-term effects of these medications are, and especially not in pregnancy. So got to come off with them there. Number three, before, when we go into IVF, you have to be off these medications at least for a week before going through your retrieval. So at minimum 1 week. Is that what you tell your patients, Dr. Amos?
I even tell them from the minute they start stimulation, they have to be off of it. And the reason why is, if it was up to anesthesia, it'd be 2 weeks. And because it does cause gastric delayed emptying. So what happens is that what keeps your stomach fuller is that the food's in there and it doesn't, it doesn't leave it. So you feel full all the time. But the problem is that if you're under anesthesia, you don't have a protected airway and you can vomit that up and then you can breathe it in. So that's the reason why they would like to be off for 2 weeks. But I tell people from the point when they start to stim, like basically when they're about ready to start the down rec, no more. And that usually gets them the 2 weeks they need. Yeah.
One other interesting point, because I know, and I just want to mention this before we hop off. Somebody earlier mentioned about, PCOS and GLP-1s in particular. And I think one of the interesting studies that has come out was showing that there's people that I think they combine metformin with GLP-1s and just GLP-1s. And they found that, women lost weight, but also their testosterone levels came down. So it's kind of, it looks like it's acting on multiple different aspects of the syndrome, kind of in concert, and it's kind of helping with quite a few of these things. So again, I think a lot more data is needed because we don't know what the long-term outcomes of these medications are quite yet, but at least in the short term, I think it looks very promising.
Yeah. And when you lose weight, fat cells themselves cause an increase in insulin, which is because of insulin resistance. Insulin itself at the ovary causes elevated testosterone. So it all makes sense. It's all that, vicious cycle that keeps happening. I actually wanted to draw that picture to show everyone tonight, but unfortunately I had to work really late and didn't have a chance to draw it to show everyone, but maybe on another show. But yeah, I mean, what a really cool topic. We gotta maybe do like 3 more shows on this just to keep it going. And I really appreciate everyone that came on. I mean, those are questions that were fantastic. I really appreciate your time too, Dr. Salem. Anything else you have to add before we go?
No, I really appreciate the people coming on. It makes it so much more fun for us. I mean, I know Dr. Amos gets sick of hearing me. So it's great when we have interesting, wonderful questions from people coming on. So please keep coming.
Yeah. And again, I mean, we can get as nerdy as you guys want. So if people call up and want to hear, super scientific stuff, I'm more than happy to get into it. We try to keep it a little bit generic, for people, but like I said, ask the questions. There's no dumb questions. So make sure you reach in. Thanks so much for everyone coming. And we'll see you guys in about 2 weeks. Okay.
Take care.